Hello, my name is Terry Gordon. I'm currently a DNP student at the University of Arkansas for Medical Science. Today I'll be discussing my quality improvement project. It entitles Microsystem Evaluation, and it's also currently at the University of Arkansas for Medical Science. On this slide, I'll be going over the mission and the values of UMS, and that is to improve the health and well-being of Arkansans by educating health professionals and the public, providing high quality and family centered care and specialty expertise, advancing the knowledge and translating discoveries into health improvements. UMS vision is by 2029 is to lead Arkansas to be the healthiest state by care, education, and research. And here are some of the core values listed right there at the bottom. UMS is broken up into two basic systems that runs the whole hospital. You have the Microsystem, which is the health system, the hospital leadership, the quality and safety committees, and for this project, you'll have the cardiology division. The microsystem is the emergency room, in which we'll talk more about on the slides to come. So, what is the role of the department, the emergency room department, well, as a microsystem? They strive to deliver rapid, evidence-based, compassionate emergency care to all Arkansans 24 hours a day, 7 days a week. It's the only level one trauma center in the state of Arkansas, serving some of the most critically ill and injured. It's the state only academic center provided high quality care to Arkansas. And right there listed below is some of the external and regulatory systems, such as the Center for Medicare and Medicaid Services, the Joint Commission chest pain certifications, the Arkansas Heart Association, and the American College of Cardiology. So, what is the purpose? I'm going to discuss the 5 P's, and we're going to start with purpose. So, the purpose of this QI project is to deliver prompt evaluation of the acute coronary syndrome, which is ACS, with a checklist-based triage system. This system will correspond with the UMS aims to enhance the patient outcome and to ensure the compliance with the benchmarks listed from the regulatory systems from the slide before. The next framework is patients. So who do we serve? In 2024, the emergency room served over 61,000 people coming from all diverse backgrounds, some underserved population, and most of them, pretty much all of them, have high cardiovascular risk comorbidities. So why do we do this? It's to provide rapid ACS recognition, evaluation, and access to evidence-based care for all. And what we do for the patient, if you get through triage faster, you'll have better communication with the staff. This project will also help with the delays in EKGs and aspirin administration times. The next framework is professionals. So who are the providers? Currently, we have the nurses. We'll be focusing on the triage nurses right now. The ED physicians, in advanced nurse practitioners, EKG techs, emergency room medical services, which is EMS or MEMS, the pharmacists, the ED admissions, and the IT specialists to help us with this project. Currently, the STEM team meets twice a month to stay up to date on compliance on people who come in with acute coronary syndromes right now. And all together, they have a monthly meeting with the interdisciplinary teams, which includes the ED physician, the cardiologist, the ECMO team, and the STEMI team. So the process. This is currently the routine. The current process that we have is you go through triage as a patient, you wait for the provider. The provider then orders a EKG, orders labs, aspirin if it's not contraindicated, and then you wait for a room assignment. And all this can end up to be delaying of your care at times. In the future, the step 2, which I plan on talking about in the future, is for the patient coming to triage, the nurse sends a trigger, which also promotes this checklist. The ACS orders are activated if criteria are met, and we'll discuss the criteria later on in the project. But you'll have an order set, which include a full set of vitals, the EKG, which is to perform less than 10 minutes. You'll also get aspirin in the triage room. You'll get an IV excess. You'll get cardiac enzymes ordered and oxygen if needed. The next step, the provider will be notified of the order set, and then the patient will leave hopefully for PCI, which is percutaneous intervention. On the 5 P's and patterns, it is actually the outcome and the trends. Currently, the door to EKG time is between 5 to 10 minutes. Nationwide, after the EKG is performed, it's reviewed by the ER physician to assess whether the patient having a STEMI. And then the patient waits for a room assignment. You get additional cardiac enzymes ordered if it's not a STEMI or if it's just a non-STEMI. And then aspirin is given after the second enzymes are ordered. And my hope is to get the benchmark less than 10 minutes in the ER, according to the ACC and the AHA guidelines. Give aspirin either a 162 or a 324 immediately in triage if it's not contraindicated, and provide a rapid triage checklist with appropriate alerts sent to the ER physician. Is to perform the EKG immediately, hopefully within 5 minutes. Administer aspirin, oxygen, like I said before, if the sats are less than 90% in IV. So, what are the opportunities for improvement? I hope to get a checklist in the EMR to focus on the ACS. We're going to also assure that aspirin is actually available in the Pyxis and the triage. And if not, we're going to contact pharmacy for any shortages. The other opportunity for improvement is to ensure that all nursing personnel are able to identify ACS. By this, we'll make sure that all the personnel have completed the Emergency Severity Index, which is the ESI, which is a test that's needed before you can go and triage any patients. Also, we're going to try to maximize any EKG technician, especially at the peak hours of the time, which is usually at the shift change of every hour. That's when we need the most staff. But we also going to make sure that all staff members in the ER are up to date and knowing how to do EKG with minimal supervision, so everybody can know how to do an EKG. So why do this matters? So the problem we will be with, it'll be delays in the door to EKG, which is greater than 10 minutes, or the inconsistency of aspirin administration, which also lead to morbidity or mortality in patients with ACS, which also lead to poor compliance with those regulatory systems. And I got this right here. It said every 30 minutes delay in reprovision, such as going to PCI, is associated with a 7.5 increase in 1 year mortality of patients. So the focus is to implement a nurse-driven triage checklist for suspected ACS. Like I said, with EKG, aspirin, cardiac enzymes that are triggered without the physician orders. In return, this benefits the UMS mission, help faster ischemia recognition, decrease patient anxiety, and improve the door to PCI time, which is the goal of 90 minutes. And here are some of the connections to the national quality aims. We'll be using the Institute of Medicine, their six safety domains, the quadruple aim, which improve patient outcomes, experience, and reduce the cost of hospitals. The Healthy People 2030, which reduce the burdens of the cardiovascular disease and improve emergency care timeliness. And we also use the CMS, National Quality Strategy, which aligns with better care, smarter spending, and healthier people. And here are some of the references currently. Thank you.